Good afternoon, everyone. Thank you so much for joining us for today's webinar. My name is Elizabeth Nijinsky, and I'm the Vice President and Publisher of Nursing at Springer Publishing Company. For those of you who may not be aware of Springer Publishing, we are an award-winning publisher of nursing and healthcare content featuring books, apps, journals, and digital products. Today, we have the honor of presenting Blowing the Roof Off of Point-of-Care Ultrasound, also known as POCUS, with Drs. Theresa Campo and Keith Lafferty. And to give you some biographical information, Theresa M. Campo, DNP, APRN, FAANP, and FAAN, is chair of the Department of Emergency Medical Services and the director of the Emergency Nurse Practitioner track, as well as the associate clinical professor at Drexel University. Clinically, she is board certified as both a family nurse practitioner and emergency nurse practitioner, and works part-time as a nurse practitioner in South New Jersey. Dr. Campo has over 30 years of experience in emergency medicine, including pre-hospital, emergency, department quick care, and trauma, and is a founding board member of the American Academy of Emergency Nurse Practitioners, which is a national organization. Keith A. Lafferty, MD, FAAEM, received his MD from the Medical College of Pennsylvania. He spent 10 years in full-time academia as a medical student director and a critical care director. He currently is the co-director of emergency medicine at Gulf Coast Medical Center, director of fire-based EMS in Fort Myers, Florida, and adjunct assistant professor of emergency medicine at Temple University. As a physician, Dr. Lafferty specializes in emergency medicine and practices in both Philadelphia and Fort Myers, Florida. Before we get started, I just want to mention that this webinar will be recorded. If you miss any portion of the presentation, you can find the video on Springer Publishing's website, which is www.springerpub.com/videos, 5 to 7 days post-event. If you have any questions during the presentation, please type them into the question box in your Zoom control panel. I will bring them up at the end of the presentation. If you have forgotten to ask a question, there will be a brief survey sent at the end of the webinar, and you can include your question there. So now, without further ado, we will turn the presentation over to Drs. Campo and Lafferty.
Hello, everybody, and welcome. I'm Theresa Campo, and I'm going to start the first part of this session. And now that you've heard a little bit about us, we'd like to get to know you. So if you don't mind, please let us know whether you are a nurse practitioner, a physician assistant, a physician, or a student, or something else. So it looks like we have the majority of nurse practitioners, but we also have some physician assistants and some students with us as well. So everybody, welcome. What clinical setting are you currently practicing in? Is it primary care, urgent care, emergency department, critical care, corrections, rural access hospital, an inpatient hospital, or another area? Okay, we have a nice mixture. We have 37% inpatient hospital, 19% are primary care, and 19% emergency department, 7% urgent care. That is really awesome. And then we have some other areas that we did not mention. Excellent. And do you regularly use point-of-care ultrasound in your practice? Wow, almost 50-50. So we have 46% said yes, and 54% said no. Well, today we're going to talk about the utilization of point-of-care ultrasound in clinical practice. And then Dr. Lafferty is going to give a more descriptive discussion on the rush exam, which is the rapid ultrasound for shock and hypotension. Next slide, please. So ultrasound has been in clinical practice for quite some time, longer than I think most of us would imagine, but it's growing rapidly. It's becoming an integral part of practice. And it's to the point that, you know, a lot of us have heard the adage that we will no longer be using stethoscope, that ultrasound will take its place. And really, it is becoming true. Ultrasound can be utilized from head to toe. It can assist in rapid assessment for potentially life-threatening problems. It also is very useful in landmarking to make procedures much more safe and effective, as well as other guidance that we could use. It's safe, it's effective, it's non-radiating, so there's no radiation exposure that could be a risk in other medical imaging, such as CAT scan, PET scans, radiography. So it is safe and effective. Next slide, please. So point of care ultrasound, growing exponentially. It is used in multiple areas. So it's not just for the hospital anymore. It's being used in urgent cares, ambulatory care, critical care access hospitals, in freestanding emergency departments, primary care practices, specialty practice, and also paramedics and transport, advanced practice nurses, PAs, RNs, are using this during either inter-hospital transport as well as pre-hospital care. And the medics are able to do not only vascular access with the ultrasounds, they're doing Efast exams. They are checking intubation. So it really is something that is growing and being used in so many different areas, and really has just blown the roof off of our clinical practice. It helps us in making real-time decisions. It has decreased mortality and morbidity. It eliminates that diagnostic delay. Maybe there's already a patient in CAT scan and we need to get this patient down there quickly. It's time consuming. You're going into a whole nother department where now it's being done at the bedside. It increases procedural precision and safety, and minimizes the complications that potentially could happen, such as causing a pneumothorax while putting in a central line. It also is safe, efficient, and cost-effective. On the right-hand side of the slide, you'll notice cell phones and tablets with a probe. And these are products that are now available for individual use. You can purchase the probe and then also a subscription, and it can be correlated and utilized with your EMR in the hospitals or in your practice. So there's other ones that are out there, but just wanted you to know that they are available, they are cost effective. You know, most of your ultrasound machines run $18,000, $20,000, $30,000, where you can purchase these probes at a much lower rate, $1,000 to $3,000, and also have a subscription if you choose. So there's a lot of options out there, and I just wanted to bring them to your attention. Next slide, please. So ultrasound is used to assess and diagnose. There's lots of different ways that we can assess our patients. The Efast exam, and I'm going to talk about some of these in a little bit more detail. The Efast is utilized in trauma. The rush is used to look at the patient that is hypovolemic. What does that cause? What is happening? What does the IVC look like? So it gives us a little bit more information. Is it cardiac related? We also can do cardiac with echocardiogram, either partial or full exams. We can assess the aorta. Is there a dissection occurring? Is there other abnormalities that we can identify? We can look at the biliary tree in the right upper quadrant to see if there is an obstruction or problems with the gallbladder. We can evaluate the kidneys, look for hydronephrosis, obstruction, kidney stones. In pregnancy, we can utilize it throughout pregnancy, looking for early pregnancy complications. Is there an intrauterine pregnancy? Are we dealing with an ectopic? and later in pregnancy, we can evaluate not just the size of the fetus, but also, is there a previa? Is there an abruption? What is going on with this patient? Giving us real-time information. Ocular, we can look for lots of abnormalities. We can also do pupillary checks in patients that have trauma to the eye with excessive swelling that doesn't allow us to get a good evaluation of pupillary response, as well as if there's a globe injury or other problem, foreign body that has occurred. And then looking at not only just the lower extremity for DVTs, but also utilizing it in assessing musculoskeletal disorders. Next slide, please. So the Efast exam is an extended focused assessment with sonography for trauma. Initially, this was just the FAST exam, and it has been extended with the number of views as well as evaluation of the pleura for pneumothorax in trauma patients. It takes 3 to 5 minutes to perform. There are 6 to 8 views utilized, which you can see on the right-hand side of your screen. And it basically has replaced diagnostic peritoneal lavage. So going from an invasive procedure to a non-invasive procedure that not just gives us information within the abdominal cavity, but now is giving us additional information of the lungs, the heart, what other injuries are there. It is highly specific, highly sensitive. It's reduced DPLs from 9 to 1%. And has reduced the CT scan use from 47 to 34%. Next slide, please. Now, the Rush exam is a rapid ultrasound for shock and hypotension. So, all of us have had this happen, especially in the emergency setting, where patients come in hypotensive, but we're not sure what's going on. So it helps us to rapidly identify some of the causes of hypotension that can be either unfounded or undifferentiated in a timely manner. We're evaluating the heart, the aorta, the inferior vena cava, and abdomen with optimal additional views of the lungs and deep veins of the lower extremities. It also is highly sensitive and specific. Next slide, please. So in evaluating a pneumothorax, what we're looking for is normal versus abnormal. In normal, we're going to see that lung sliding. We're going to see what's called a seashore sign. And on the right side of the screen, you can see a video that will demonstrate the sliding of the lung when the person inhales and exhales.
Interspersed with small septae.
And then we can assess for abnormality of a pneumothorax in seeing cessation of that lung sliding, and we lose that seashore sign.
Cessation of lung sliding in B mode.
So the ultrasound is extremely helpful. In ocular ultrasound, we have visual conditions that occur, but sometimes can be difficult to assess in our various settings. And ultrasound is really beneficial in confirming a globe rupture, in looking at a cataract, looking at a lens dislocation. Is there an intraocular foreign body that we just aren't able to see? Vitreous hemorrhage and detachment, retinal detachments, and being able to differentiate those 3 different abnormalities. Looking for a retrobulbar hematoma and emboli, as well as signs of papilledema and increased intracranial pressure. So what we can do is actually look at the back of the eye and give us an idea of increased intracranial pressure. Next slide, please. So here we have normal anatomy. On the left, you can see a drawing of the anatomy of the ultrasound probe at the top of the picture, the layers of the eyelid, the cornea, the iris, the lens, that vitreous posterior chamber, the retina, and the optic nerve. On the right-hand side, we can see the anatomy by ultrasound and really appreciate the difference between a drawing and the image. And when I tell my students with any part of medical imaging is to consider medical imaging to be almost a foreign language for your eyes. You're seeing things differently, and you need to train yourself in what you're seeing, why you're seeing it. So it's always important to know your normal anatomy, physiology, but also pathology, and what effect you would see actually on your medical image. Next slide, please. Here we can see a retinal detachment. And again, the left side is a drawing demonstrating the retina that is detaching from that macular region. And on the right-hand side, we can see the detachment of that retina. You can see where it's anechoic and hypoechoic, or black and dark in shade. And that is showing you where that retina has detached with that macular region. So really can appreciate the ultrasound. And it's, you know, sometimes easy to point an arrow and understand what you're seeing, or say that that's what it is. But when you have a drawing side by side, a lot of times that helps us in learning exactly what we're visualizing. Next slide, please. So here we have a partial and complete lens dislocation. So in the left side, you can see where that lens is out of place, but not completely out of its normal positioning. And on the right, you can see where that lens has completely dislodged and is out of its normal alignment. Next slide, please. Here we can see an ocular foreign body on the surface clinically and visually. We can see that there's a foreign body. We can also see that there's a globe injury here with the appearance of the iris and the pupil. And in the right-hand side with the ultrasound, we can additionally see that there is a foreign body intraorbitally. And you can see that in the bottom left section of the picture, where the foreign body is actually casting a shadow. Next slide, please. So ultrasound guidance for procedures helps us to identify anatomy and abnormal anatomy. You know, not all of us read the textbooks and know where our body parts are supposed to be. Some are shift a little bit. We can have anomalies. So the ultrasound allows us to identify that and make corrections in our techniques to make sure that we are now doing the procedure safely. Can help us to identify those landmarks, safely perform procedures, again, having real-time images. We're not getting a CT, having a delay, and then looking at whatever procedure we need to do based on the results. So real-time image is really important. Next slide, please. So here we can see the ultrasound probe on the anterior neck, and the ultrasound gives us the ability to differentiate the thyroid cartilage from the cricothyroid membrane and also that cricoid cartilage, so we know exactly where to go. And this is extremely helpful in those obese patients or patients who have really large, thick necks, and making identification of that anatomical landmark difficult. Next slide, please. Here we have a pericardial effusion. We can see the left ventricle, the right ventricle, the mitral valve fully open during ventricular diastole, but we can also see the fluid accumulation and the large effusion, okay? And Keith, if you don't mind just demonstrating, even though it says it, the large effusion, no evidence of tamponade, we have an arrow going to the top and the bottom right there. So that's one area that we see the fluid, as well as higher up in the picture. Thank you. Next slide, please. And not only can we identify that effusion, but now we can use ultrasound to guide us in doing a pericardiocentesis in a safe manner, because what that allows us to do is not only identify the landmarks, but also to know when our needle is in the area of the fluid, that we're in the right spot, so that we can do this again much safer. Next slide, please. With IV access, this is beneficial for peripheral lines as well as central lines and arterial lines. So we can get the anatomical landmarks in the image on the right, we can see where the bicep is. We can see the paired brachial veins, as well as the artery and the median nerve. And again, this helps us to do it in a much safer manner so that we are not cannulating an artery or hitting the nerve, causing further damage. And when accessing any vasculature, we can do it in either, excuse me, pardon me, we can look at two views. We can look at the long or short axis. And as you can see, the image to the left is showing you the position of the probe, the needle with the vessel. And then on the right-hand side, you can actually see in that long axis, the needle entering that vessel, making sure that we're not going too far and that we're keeping the appropriate angle. And then when we look in the short axis, we can again see the needle within that vessel. Next slide, please. These are just some images showing you the differences. You can see the internal jugular vein in when it's non-compressed as opposed to compressed, so that again, we know exactly where we're going and we're missing that carotid artery. Next slide, please. Again, just side-by-side demonstration of central venous access. On the right-hand side, we can see the ultrasound images and then matching them up with the drawings. Next slide, please. Now, when looking at arterial access, not only can we utilize one mode, but we can also utilize the M mode in looking at the rate and rhythm while we are accessing the arterial vessel. Next slide, please. And this is a video. We're just going to demonstrate the use of ultrasound in guiding us in our landmarking, but also for full access.
Note the femoral artery is to the left, that is the patient's right. As can be seen by the thicker wall of the femoral artery and the inability to compress the femoral artery, unlike the femoral vein, which is to the right and most easily compressed. To further delineate the femoral artery, color is added and one sees the arterial.
Okay, so next we can utilize it with some of the regional anesthesia approaches that can be utilized with ultrasound guidance. And here you can see the median nerve that's hyperechoic in the center of the picture. And this is in the short axis of the forearm. So again, gives us not only visualization of our landmark, but next slide, please. It also can tell us that our anesthetic is appropriately injected by the changes you see of the fluid once you instill it. And you can see that here with the hydrodissection after injection of the medial nerve. Next slide, please. Foreign body identification and removal. Again, X-ray is excellent if we have a radiopeg foreign body. Ultrasound is beneficial regardless of the foreign body. So here we have a very large wooden foreign body and heel. And on the right, you can see where the needle driver is entered to assist in removing that foreign body. So it tells us that we're where we need to be to go ahead and grab that foreign body and take it out in its entirety and make sure we're not leaving anything behind. Next slide, please. Differentiating cellulitis from abscess. On the left side, we can see that this is a cellulitis. It has a very nice cobblestone appearance, kind of looks like cobblestones in a creek. And then on the right side, we can see the skin layer at the top of the picture with the area that's hypoechoic, and some areas are actually anechoic or completely black from the abscess and the underlying vasculature. And this is really ideal because this allows us to not go too deep in our approaches and get anywhere close to the underlying vasculature. Helps us to identify, again, any complications that could potentially happen with a blind approach. Next slide, please. With peritonsular abscess, and the right picture is just a blow up of half of the one on the left. And this is showing you, and Keith, if you don't mind demonstrating, how close the tonsils and the abscess are to the carotid artery. And if you have a patient that the carotid artery is anomalous, where it's not in exactly where the position it should be, we don't want to be anywhere close to that when draining that peritonsular abscess. So again, not only is it helping us to identify landmarks, it's helping us to identify underlying anatomy to make sure we're avoiding any potential complications of cannulating or injecting through the carotid artery. We want to make sure we're safely getting to that abscess and drawing off the purulent material. Next slide, please. Here you can see how beneficial it can be with depth. So on the right-hand side, we can identify that reddened area within the scope is our carotid artery. We can get a measurement of how deep that carotid artery is in relation to the abscess that's above it, so that we can put the tape on the cap of our needle, cut down to make sure that we're well away from the artery, but well within that abscess. Next slide, please. Here we can see the benefits of use in musculoskeletal. On the left-hand side, you see where the probe is positioned. The middle picture is again giving you a drawing of what you're seeing on ultrasound. And on the ultrasound, we can see the effusion between that patella and femur. Next slide, please. It can help us identify nursemaid's elbow. We can see the fat pad that develops. Could also help us to identify an accompanying fracture prior to doing any reduction. So again, just demonstrating how beneficial it can be to not only identify anatomy, the underlying injury, illness, or problem, and what is our best approach at correcting it. Next slide, please. And here we can utilize ultrasound to confirm placement of tubes. So in the middle two pictures, in B, we can see the trachea and we can see the esophagus. If we look at C, you can actually see the NG tube being passed in the esophagus. We know that it has proper placement. And then we can also look at it abdominally. So it is absolutely a mainstay of clinical practice and can make our lives much easier as long as we have the resources available. Next slide, please. And I'm going to turn it over to Dr. Lafferty.
Okay, hello everyone. I'm just gonna kind of piggyback Theresa, and as Theresa kind of just conveyed and just shared a broad overview of POCUS or point of care ultrasound throughout many clinical pathologies, procedures, even diagnoses. We're going to look at one specific entity, specifically the hypotensive patient, and more specifically, the undifferentiated hypotensive patient. In other words, a patient you're presented that presents that's hypotensive and we're not sure why they're hypotensive. Before I begin that, I'm just going to go over very quickly a couple articles in support of taking low blood pressure seriously. In the Journal of Trauma in 2010, they presented a paper entitled "Just One Drop: The Significance of a Single Hypotensive Blood Pressure Reading During Trauma Resuscitations." This was a one-year prospective observational study. And basically, patients with even a single systolic blood pressure of 110 or less during traumatic resuscitation were evaluated. And that was 145 patients. Using a logistic regression, the authors found that 38.1%, almost 40% of patients with an isolated systolic blood pressure of 105 or less underwent immediate or needed immediate therapeutic operative or endovascular procedures. That's contrary to the 10.4%, So 40% versus almost 10% with an isolated systolic blood pressure of 105 or greater requiring those procedures. So basically, patients were greater than 12 times more likely to undergo immediate therapeutic intervention with a single drop of blood pressure of 105 or less. So we have to take these hypotensive patients seriously and not think it's just an erroneous figure and just throw it out. Also, just in a quick review, if we look at ATLS, it teaches us that hemorrhagic shock is not always clinically apparent by the static vital signs. And you have to go into a class 2 or class 3 stage of shock before you see a drop, an increase in heart rate or a decrease in blood pressure. And this is, anyone who's done taken ATLS, you'll appreciate this. Now this is showing a class 2 shock state is when you start to see a tachycardia or increase in heart rate greater than 100. And that was where you lose 15 to 30% of your intravascular volume or your blood. It's not till you hit 1,500 or 2,000 cc's, 30 to 40% of your blood or intravascular volume, that your blood pressure decreases. So when you see someone with a isolated decreased blood pressure, take them serious, whether it's, and if you can extrapolate this, so it's a traumatic patient that's hypotensive or even a non-traumatic patient, certainly more so in the elderly patients and beta blockers and so forth. So basically, this article showed that even an isolated episode of hypotension may be an early indication of impending shock or shock present. I'm going to go ahead and skip this slide. The second paper, and the last one I just wanted to go over briefly, was also in a journal of trauma in 2010. Whoops. Let me see. And basically this one was entitled Normal Presenting Vital Signs Are Unreliable in Geriatric Blunt Trauma Victims. This was a retrospective chart review study that looked at heart rate and systolic blood pressure in the young, in which they described of 17 to 35 years of age, and the elderly, 65 years of age and older, in blunt traumatic patients. They had over 2,000 patients in each arm. That is over 2,000 patients in the young arm and 2,000 patients in the elderly arm. And if you look at the mortality difference, it's while it's startling, it's not surprising. 11.4% in the elderly arm died, while only 2.4% of the patients in the younger arm died. The authors showed that in the elderly, the mortality is greatly increased with a heart rate greater than 90. That's it. While in the young, the mortality rate showed to be increased with a heart rate greater than 130. Big discrepancy there. And with systolic blood pressure in the elderly, the mortality increased with a systolic blood pressure of just less than equal to 110. While in the young, it was a systolic blood pressure of less than or equal to 95 that increased in mortality. The authors concluded to be wary of the normal or near normal vital signs in blunt traumatic patients in the elderly, especially when you start out in calcium channel blockers, beta blockers, and other things to it, it increases. So just a quick review of shock, then we'll go into some rush exams and some cool pictures and videos. I like the break shock up into two ways. Clinically at the bedside, non-distributive or a cool shock, you just palpate the patient's skin. And under the cool shock, you have hypovolemic shock, okay, and that could be dehydration or hemorrhagic loss of blood. Cardiogenic shock, obstructive shock, big PE, tamponade, pulmonary embolism. And often these obstructive shocks, again, tamponade, pulmonary embolism, pneumothorax, they need something done immediately. And then distributive shock, which is a septic shock, anaphylactic shock, or neurogenic shock, where you vasodilate. And these patients, if you palpate the skin, are warm. It's just a good way to break it up. And basically, I'll paraphrase the slide. Studies have demonstrated that the use of bedside ultrasound greatly increases sensitivity and specificity for diagnosis. An example of this is Beck's triad. You know, only 1/3 of the patients is going to get all the clinical signs of a Beck's triad for cardiac tamponade. I mean, who's going to hear muffled heart tones and, you know, all these things anymore, and in busy emergency department or ambulances or on the floor? It's just, you know, the sensitivity just doesn't come close where you can just take a look at it with an ultrasound. I always give them, my students, an analogy. If your car is knocking under, you know, you don't you don't put your ear up to the hood, you open the hood and take a look in. So this is certainly become a replacement of the stethoscope. Okay, so the rush exam basically looks at an undifferentiated hypotensive patient. And it says, you know, with this very sensitive and specific tool that can look in the body, let's see why they're hypotensive. This is just kind of an algorithm. I'm going to just have everyone look at it and then leave it. But it's a good algorithm to keep in mind as far as doing the rush exam. And basically on the rush exam, it breaks things up into 3 areas. And I like the simplicity of this. It looks at the pump, which we'll talk about first, the tank, and then the pipes. So the pump, what do we mean by the pump? Well, that's the heart. The tank is the capacitance vessel, the inferior vena cava, the IVC. What's the patient's preload? So is there a problem with the pump? You can't get the blood out, cardiac output, O2 delivery, all that good stuff. Is there a problem with the tank? The preload is a problem, or potential tanks. Pleural space for pleural effusion, peritoneal space for peritoneal hemorrhage or so forth. And the pipes, the big pipes, the aorta, is it ruptured or some of the pipes blocked, like the deep veins in the legs? So that's how it breaks it up in a very simplistic way. So let's look at the pump first. The pump is basically a very limited echocardiogram. None of us are pretending to be sonographers, and the sonographers that we work with are phenomenal. And you know, very respected. We're basically doing a binary yes, no, point of care limited ultrasound. And when it comes to the pump, we're basically saying we're going to look at the sac to see if this patient's in tamponade. Again, this is the undifferentiated hypotensive patient. We're going to look at the squeeze. You know, do they have a cardiomyopathy? Do they have big MI, big anterior wall MI? And we're going to look at the right chamber to see if they have a big PE, either a massive PE or a submassive PE, something causing the hypotension. This is just a pretty cool and great a piece of graphic art. And if you look at it, one have to remember, in order to really conceptualize and interpret point of care ultrasound, especially cardiac ultrasound, one really must comprehend cardiac chamber anatomy combined with, and this is important, ultrasound image orientation. So without going into details, this really lays this out. There's four views. One should master looking at the heart, but you always start at one view. The easiest view is in the lower left, the subxiphoid here. And this is cool because it takes an anatomical sketch, puts it next to the ultrasound, and shows you where to put the probe and even the pointer. The next easiest view, and the one in master, is the apical 4-chamber view. But this gets in a little more detail. I want to present the forest now more than anything else. So if you look at this, we're thinking a hypotensive, undifferentiated. Why is this patient hypotensive? Start at the pump, the heart, and then look at these, you know, is there a tamponade going on? Well, in this patient, I'm not going to play the whole video here, but in this patient, you can see not only there's pericardial effusion, but look at this right ventricle, which sits closer to the skin. That's why gunshots and knives hit RVs and RAs first. But that's diastolic collapse, and diastole, that is not expanding. So this is not only pericardial effusion, this is a tamponade. We have diastolic collapse of the RV. And you can see here an ultrasound that's labeled, the anatomical drawing, beautiful. This just goes in, and I'm just going to glance at this, the procedure for a pericardiocentesis. I don't want to get away from the pump right now, but it's just showing you, because the heart is very anterior, you don't want to go at a 45-degree angle, you want to go at a 30-degree angle. This is just showing a picture of doing a quick pericardiocentesis using ultrasound guidance. Again, this is an out-of-plane ultrasound pericardiocentesis. But you can see how you would be guessing right now without the ultrasound. You would have no idea what you're putting that needle into. This is just showing the equipment labeled, just a very nice description of such. And I'm just going to show this for a few seconds of a formal pericardiocentesis that we captured. So I'm going to fast forward a little.
Is again accomplished with direct ultrasound visualization based upon the best view of fluid. In this case, as in most cases.
And you can see you get a little return. This is all being done under ultrasound guidance.
Upon pericardial fluid
And then
return,
you can put
in
your
this
needle, your
case, a
wire
bloody
in
return.
and use the Sellinger technique. And then somewhere down here, you can see this beautiful
Ultrasound. In this case, a
image in real time. You can see that
approach
needle go in there.
was used
This is
with
just
the apical
absolutely
fore view.
stunning. This is also a picture of a needle entering the pericardial sac. And with the help of, with the injection of aggregated saline shaken up and you can actually see the saline inside the pericardial sac. I can't believe the lawn people here right now, and that's what you're hearing. Okay, I'm going to speak loud then. This is a subxiphoid view right now. And you can see besides the tamponade, you can see this left ventricle. You can see this very poor squeeze of this left ventricle. This is a cardiomyopathy. You don't have to be a sonographer or an echosonographer. This is a poor squeeze. This should be squeezing about 50% wall to wall. And you can see the drawing here again to match for the student to read or professional to read. This is showing another view of the apical forechamber. Again, it's not just showing the view laid out, which is the left ventricle, right ventricle, right atrium, left atrium. You can see the anatomical drawing, the ultrasound, just nice stuff. This is showing the other reason for a pump failure. This is a massive pulmonary embolism, and you can see this very, very large right ventricle. That right ventricle should not be larger than the left ventricle. It's basically a 1.1 ratio or a 1-to-1 ratio. That's very much larger than the left ventricle. That shouldn't happen. There is something obstructing the pulmonary artery to give this massive dilation of the RV. And if you look again, the left ventricle has a higher pressure. That septum, intraventricular septum, should be going from left to right. It's going from right to left. That's a paradoxal septal movement. That's also a sign of a massive pulmonary embolism. Okay, let's talk about the tank. So what about the tank? The tank is basically the IVC showing the preload of the patient and also potential tanks in the peritoneum and the pleura. So I like to look at a lot of patients' IVCs, especially in this day of us resuscitating septic patients more and more. So this could be a traumatic patient. When's the end goal for resuscitation? This is the IVC collapse. If a patient takes a breath in and their intrathoracic pressure becomes more negative, it's going to draw more of the IVC of the venous blood into the RV, and that IVC is going to collapse. And you can see it here on a real-time video. This was a septic patient, hypotensive, when we were looking how much fluid to resuscitate. This was after the initial fluid of 30 cc's per kilo. You can see that IVC collapse. This patient needs more fluid. Their intravascular volume depleted big time, and that's what they need, and that's what they receive. As opposed to this patient has no respiratory variation whatsoever of the IVC. You can see a plump IVC there with no respiratory variations. There's actually correlations of the IVC with the size itself on the central venous pressure, and that's very nicely depicted here. And you can see basically, we use as a rule of thumb IVC measurement of 2 centimeters as a point of a metric, saying if they're greater than 2 centimeters on a static reading, their intravascular volume euvolemic first less than 2 centimeters, where they would need more fluid. That's not as sensitive as using respiratory variation. I'd like to say if it's fat or flat, it's helpful. And then for potential tank areas where fluid could be going, everyone knows about the Efast exam. These are beautiful pictures showing it. You can see the right upper quadrant there, the probe on the patient. And this graphic art actually shows the channels where the peritoneal blood or peritoneal fluid, the way it flows. And this is a very nice depiction of that. If you have a supine patient and you actually put a conduit in them and pour fluid in, saline, whatever, the most dependent area is Morrison's pouch. You need about 200 cc's of fluid, and you'll start seeing black at that potential space between the peritoneal reflection between the kidney and the liver. Right here, this is a normal ultrasound of Morrison's pouch, right upper quadrant. You can see there's no black. no fluid, or certainly less than 200 cc's of fluid. And there's a sketch of it as well. And here you can see the anechoic fluid this patient has. If this was a gunshot or blunt trauma, this anechoic fluid would be blood. This could be a ruptured ovary. It could be an ectopic pregnancy. It could be a AAA ruptured, but there's fluid in the peritoneal cavity. This just goes into how to do a fast exam. This will be, I'm going to abbreviate
right
this.
upper quadrant view, visualizing the inferior pole of the kidney and above the diaphragm superiorly. Subxiphoid cardiac view, assessing for pericardial effusion. Left upper quadrant view, visualizing the inferior pole of the kidney and above the diaphragm superiorly. Sagittal and transverse suprapubic views, assessing for free fluid around the bladder and pelvic organ.
So as Theresa stated earlier, this has pretty much eliminated DPLs in clinical practice. The other potential space is a pleural space. And you can see this chest x-ray. This is the PA in the lateral here, showing no pleural effusion. You can see this chest x-ray to the right on the PA showing a meniscus or a pleural effusion. And on the lateral, you need about 200 cc's to fill up the posterior costophrenic angle. And then you'll start seeing it on the PA. So if you have a one-view chest x-ray, you could have the posterior costophrenic angle full before it starts spilling over into the higher lateral costophrenic angle. So there's limited sensitivities in the chest x-ray for evaluating pleural effusion. This is a CAT scan on the axial cut, and this is obvious on the right pleural effusion, but this takes time and so forth. This is an ultrasound, bam, right at the patient's bedside. This takes a few seconds. And certainly for guidance and for a thoracentesis, it's standard of care to do it with ultrasound guidance. This is just showing not only like the pictures itself of a pleural effusion, but this is an anatomical drawing of it, and you can see it's kind of compressing the lungs. And when it does that, the alveoli themselves get compressed, and you get atelectasis. And what happens with that is you get blood from the venous side going back to the arterial side, but it's shunted blood. You can't have an oxygen exchange there, and that defines shunting. So if you have a pleural effusion big enough, you will get hypoxia from right to left shunting. And this is just, again, a beautiful micro anatomical depiction of a thoracentesis, the anatomy, the vessels that you want to, the vein going in the intercostal groove, why you want the needle on top of the rib. This is just showing more on a macro level at the tip of the scapula where the fluid is most dependent. On a sitting up patient, you want to avoid the seventh rib starting the spleen or the liver. This is just showing a thoracentesis setup, labeled, and this is just kind of showing off a collage of different pictures showing the various steps of a thoracentesis. The last thing is the pipes. And basically with the pipes, you want to say, hey, is that aorta ruptured? And also, hey, does this patient have DVTs in the leg veins? That could lead to a PE. This is just showing a AAA evaluation. And it's, pretty easy to do. It takes a few seconds of don't forget 50% of the AAAs present with back pain. Someone presenting with abrupt pain, which often could be a vascular source of pain, it takes a few seconds instead of having them wait and then, wait in a waiting room, wait in the office, wait in your emergency department, then wait for a CAT scan. This is a time-sensitive diagnosis, and it takes a few seconds to lay that probe on. And here's a sagittal look at the aorta with the celiac trunk, which is the first vessel coming off the aorta in the abdominal cavity. And there's your SMA, superior mesenteric artery. And you can even put color flow in here and see if there's an embolism of the SMA and so forth. But there's no AAA there. There's a sagittal and there's a transverse. Takes a few seconds. Here's a AAA on an ultrasound, and it ruptured into the peritoneal cavity, which is not good. We want it to rupture a retroperitoneal where it can tamponade itself, and that's a CAT scan depiction, and there's the anatomy. So it takes a few seconds to get this diagnosis. You see this, and an acute back pain or abdominal pain, you call the surgeon, the patient needs to go to the OR. You don't need any more imaging. This is, I'm just gonna not show the whole thing.
Normal aorta.
This is just showing an ultrasound of
Sagittal
how to do a
view,
normal
assessing
aorta.
for an undulating intimal flap.
And there it is, normal aorta.
Transverse sweeps.
And
from
there's
above
sweeping
the
through
celiac
the
trunk.
aorta. Last thing is the pipes. The last thing about the pipes is the looking for DVT in the leg veins. This is the femoral artery and vein, and we're trying to see if this patient has a DVT of the femoral vein. And you can see pushing pressure once you identify it on the femoral vein, it collapses. There's no DVT. If it didn't collapse, indirectly, you know there's a DVT. This is the popliteal vein, which lies superficial to the popliteal artery, and you can see compressing that popliteal vein. It compresses. You're no DVT. We're good. As opposed to here, where you have the femoral vein, and with compression of the probe over the skin, it won't compress. You have a DVT. Same thing with the popliteal vein, where you compress on the probe and it collapses. It does not collapse. I'm sorry. So you do not have a DVT. This is just showing it's not important to lay out the steps of doing these procedures and A, B, C, D, E. It's more important to understand with the anatomy, the steps and why, and also clinical pearls of why these little tricks of the trade developed by clinicians over the years to help further explain and memory. We don't want people to memorize things. We want them to understand it. Then that's true memory. And that's it for me.
Okay, great. Thank you so much, Theresa and Keith, for that fabulous presentation. Very robust. There are a few questions. First question is, what are some common pitfalls associated with point of care ultrasound?
I'll take that, Theresa, first and then let you. I would say more than pitfalls, the biggest obstacle I see in students, and this could be, you know, PA students, NP students, medical students, or full-blown professionals in all these fields, EMS, whatever. I think one is you have to know the anatomy. You don't have to know it like a PhD, an anatomist, but you have to know the basic anatomy. Two is the orientation. So the pointer on the probe, if it's left or right, what's cephalad, what's caudal. In other words, where's the head, where's the on the screen. Once you know the basic anatomy and orientation of the probe, what you're looking at, the ultrasound, the learning curve goes up drastically, and you will not stop using it.
The only thing I would add to that is that if you have a negative exam, it doesn't necessarily mean it's 100% negative. Especially it's going to be dependent on your confidence as well as competency with ultrasound. So you still need to follow through to make sure that you have other methods of evaluation. However, with ultrasound, if it's positive, then you're done. So, you know, just getting comfortable with that and just being comfortable with your level of experience and just getting out there and trying and using it and learning every day. The more you do, the better off you will be, and the better you're going to be with your patient.
Great, thank you so much. The next question is, what are some effective ways to incorporate point of care ultrasound into an educational program?
I'll start with that one, Keith. There are lots of ways that you can integrate ultrasound into your programs. One way is to bring in experts who are proficient and experts in ultrasound in clinical practice and have them help with teaching your courses. The other way to integrate it are different programs that are out there with simulation. There are a couple, and I just want to disclose, I have no ties to any of these companies. I just know that they're out there. Sonosim is one of the major ones. They not only make simulators that incorporate ultrasound abilities, but they also have programs that institutions can purchase as well as individuals where you get a practice pad, a probe that is integrated with a computer system and gives you the simulation. So as you move the probe and you're doing, say, Efast, if you are in the wrong plane, direction, what have you, the probe reads that back to the program and helps you to adjust and learn that way. So a lot of people say, well, it's a pad in front of me, but really it's using artificial intelligence to make that real and fine tune your abilities to do ultrasound.
I would echo those sentiments by Theresa, and even the broaden it more. You know, ultrasounds now, it's used in third world countries. We had a program in Haiti where we brought a machine down, and you know, they don't have a lot of the imaging modalities we have, CAT scans, MRIs, and so forth. So ultrasound's a necessity, and it's helping a lot of third world countries greatly. It's EMS system. You know, just having any cardiac movement at all increases your chance of a ROSC, or return of spontaneous circulation, up to 50%. So it's here, it's using it. And you know what I tell a lot of my colleagues and students, if you're not growing, you're dying. And you better hop on board, because it's just, you know, who would not want to apply a more sensitive and specific imaging modality to a patient, or a diagnosis, or accuracy of doing certain procedures. And we have to embrace this technology. But there's super users you can hire. They can come out and train one, at one becomes a trainer and trains others. The companies themselves that sell the products have training sessions that come out. So it's pretty much ubiquitous now as far as the training.
And I have to bring back an old time favorite, but Keith and I had presented many moons ago on abdominal imaging, and he made a comment that I thought was unbelievable and really looking at the future. And he assimilated ultrasound with Star Trek, and, you know, Dr. Spock, and how he, or not Dr. Spock, whoever the doctor was, would basically take a probe and just kind of run it over the patient and have the diagnosis. And really, we're there. Ultrasound can be used to look for fractures. It can look for sprains, strains, you know, heart conditions, everything under the sun. And it is just literally going to become second nature in clinical practice.
Yeah, and I think that character was named Bones.
Bones. I'm not a Star Trek person. Sorry. I don't know all the people.
Okay, great. And there's another question, and I think you actually may have addressed some of this, but I will read you the question. Do you see physicians and advanced practice providers using the handheld probe iPhone devices in the inpatient setting, namely ER, ICU, etc., or is this more appropriate for a clinic setting?
I guess my turn to go first.
Sure.
This is used everywhere, because wherever there's opportunity to diagnose a patient or to do a procedure, which is everywhere, this is used. You know, trying to appreciate a bruit with a stethoscope on an abdominal aortic aneurysm, or a Beck's triad for a cardiac tamponade, when you can just look at it and measure it. There's no indirect, you know, why would someone be indirect when you can be direct? So it's used in all those clinical settings, the ICU, the emergency department, clinically, family practice, urgent care, pre-hospital. The time is now, and you know, it's upon us. And you know, everyone, it's a little on the knobology. It gives people a little angst learning initially, but the machines have gotten much more simplified. And again, they come out and teach now the knobology, so to speak. And it's people gravitate once they get it. Once they get one exam, whether usually a fast exam or an aorta, then that sets the tone, and then everything else is picked up much more quicker.
I echo that. And also, you know, it's not just in hospital evaluation anymore. The pre-hospital with paramedics, with interhospital transports, and utilizing it in any office setting. I mean, anybody can use this. You need to be trained. You can't just pick it up and think you're going to be able to find everything. It takes practice and education in order to be more proficient. But really, it's where you want to use it and help your practice and help your patients to be diagnosed and treated in a more timely manner.
Terrific. Could we go to the next slide, please. Okay, so you can see the very recent publication, Essential Procedures for Emergency, Urgent, and Primary Care Settings, a clinical companion. It is now in its 3rd edition. And this slide gives you information on adopting or purchasing this wonderful text. And you will receive a 25% discount plus free shipping for having attended this webinar. So thank you very much for your attendance and the great questions. And we're glad that you enjoyed it.
Thank you, everyone.
Thank you, everyone.